Healthcare is bleeding its most critical workforce. Before reaching their 5th year of practice, a massive percentage of nursing professionals abandon the field entirely. This timeline tracks the standard nursing career path, defined by two sharp bottlenecks. The first valley is the NCLEX RN board exam, halting thousands right at the academic finish line. The second valley is the clinical hurdle, the psychological gauntlet of early active practice. Historically, surviving these two hurdles has been treated as a matter of luck, intuition, or individual grit. But attrition is a predictable, engineerable statistical outcome. Program directors and hospital administrators often try to solve this attrition by relying on generalized intuition. They index heavily on early academic aptitude tests, or deploy broad, generalized hospital support programs. To see why those strategies fail, we have to look at the data through multivariate regression modeling. This statistical method separates overlapping variables to find the isolated drivers of success. Two large-scale studies, one by Flowers analyzing licensure and another by Laschinger tracking clinical survival, have isolated the exact variables that predict success, and the math directly contradicts standard administrative strategies. To stabilize the nursing pipeline, institutions must abandon assumptions based on isolated data points and realign their resources to the variables that actually dictate unique variance in the outcomes. Let's examine the first valley. A 2024 study by Flowers evaluated a cohort of 514 nursing students, testing academic predictors against first-time NCLEX RN success. This data table shows unadjusted regression results. Science GPA and the T-score appear to correlate strongly with passing, but when we run the adjusted model, controlling for other variables, the T-score completely loses its predictive significance. This means early-stage admission aptitude tests are statistically inefficient metrics for administrators to rely upon for final board success. Predicting NCLEX success requires looking past who a student was at admission and measuring what they actually become by the end of the program. This brings us to the two variables that retain powerful, independent significance in the adjusted model: cumulative GPA and the HESI exit exam. Just a 0.1 increase in a student's cumulative GPA increases their odds of passing the NCLEX and 35%. Then there is the massive predictive power of the HESI benchmark score. A 100-point increase in a student's HESI score multiplies their odds of passing the NCLEX 2.3 times. Late-stage, comprehensive programmatic benchmarks are the ultimate proximal indicators of licensure success. They dictate exactly where academic remediation resources should be spent. Once a nurse passes the NCLEX, they enter the second valley, active clinical practice. Here, the threat shifts from academic failure to psychological collapse. A 2018 Laschinger study tracked a cohort of 406 newly graduated Canadian nurses over their first year of practice. The data revealed a stark threat. While physical health remained stable, over 20% of new nurses exhibited significant risk for post-traumatic stress disorder. Hospitals typically attempt to mitigate this by deploying general, formal new graduate support programs and emphasizing authentic leadership from management. But the multivariate analysis reveals a brutal reality. These generalized support structures fail to prevent PTSD or protect mental health in the final model. Throwing generic administrative support at a clinical workforce is mathematically inadequate. To keep nurses on the floor, hospitals must engineer targeted psychological variables instead. This diagram outlines the variables that actually matter. There is one distinct internal characteristic that dictates unique variance in protecting a new nurse's mental health: occupational coping self-efficacy. Occupational coping self-efficacy is not general confidence. It is the specific, measurable cognitive capacity to process and overcome acute work-related stress in real time. On the other side are the external catalysts of failure. Even infrequent acts of workplace incivility act as a primer for severe burnout. That burnout fuels the two variables that aggressively drive up PTSD risk: work-life interference and cynicism. The damage is highly quantifiable. Work-life interference is responsible for a 27% increase in the odds of developing PTSD risk, and cynicism, a measurable component of burnout, drives a 28% increase in the odds of PTSD risk. Clinical survival, therefore, is determined by a highly specific ratio: the presence of internal cognitive coping skills weighed against the structural presence of cynicism. This brings us back to our timeline. Optimizing the nursing workforce requires mapping these exact statistical realities directly onto the career path. For the first valley, programs must embed rigorous HESI remediation and longitudinal GPA tracking directly into the bottleneck. For the second valley, hospitals must restructure clinical environments to eliminate work-life interference and actively train occupational coping self-efficacy. When the correct variance is targeted, the probability of attrition drops significantly, creating a more reliable, stabilized pipeline. For academic directors, this requires mandating a shift of budgetary resources away from over-indexing on entry metrics like the Ts. Those resources must be redirected into end-of-program predictive testing remediation to honor the 2.3 multiplier of the HESI data. For nurse managers, this requires recognizing the statistical failure of generalized new grad support programs in actually preventing attrition. Clinical environments must be structurally audited for work-life interference because it is a proven mathematical precursor to the cynicism that causes a 20% PTSD failure rate. Statistical engineering transforms a workforce from a matter of institutional guesswork into a stable, predictable system. Building a resilient nursing pipeline requires these specific mathematical levers applied to clinical policy.